Hi, everyone. Thank you for joining the Substance Use Response Group Prevention Subcommittee meeting today, June 5th at 3 o'clock. I'm Jessica Johnson, your chair. I'm going to go ahead and call this meeting to order. We'll start with agenda item number 1, which is a call to establish quorum. Ms. Rodriguez, do you mind assisting with the call for quorum?
Yes. Senator Doñate.
Here.
Chair Jessica Johnson.
Present.
Debbie Nadler.
Present.
Angela Nichols. And Vice Chair Eric Schoen. All right, we do have 3 out of the 5 committee members present. So Chair Johnson, we do have a quorum.
Thank you so much, Ms. Rodriguez, for your assistance with that. And thank you, committee members, for joining today. We'll go ahead and move on to agenda item number 2, which is public comment. Public comment will be received via Zoom meeting by raising your hand or unmuting yourself when asked. Public comment shall be limited to 3 minutes per person, and this is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments, but the general public until the matter itself has been specifically included on an agenda item upon which action may be taken pursuant to NRS 241.020. Ms. Rodriguez, do you mind reading out the details from dialing in from a telephone?
Sure. So if you are dialing in from a telephone, please dial 253-205-0468. And then when prompted, you'll want to enter the meeting ID, which is 825-0031-7472. And please press *9 so the host can prompt you to unmute.
Thank you. Ms. Rodriguez, do we have anyone for public comment?
So far, I see 1 hand raised from Debbie Nadler.
Go ahead, Ms. Nadler. And you are, yes. Go ahead.
Sorry. Hi there. I don't know if really I'm speaking for me or I'm speaking for the hundreds of bereaved family members who've lost a child to this epidemic, but I can't not speak right now. When you're being stabbed once by losing a child, stabbed twice by spending thousands upon thousands of dollars trying to save them, stabbed 3 times when you have worked nonstop to try to bring prevention and education to the classrooms, to try to help grieving family members, when you have tried to get billboards up, when you've tried to get the city to pay for a memorial, when you've tried to get the city to pay for lights, to honor our loved ones, when you tried to get our state to take care of our mental health needs, to take care of us, the bereaved family members, I think that should be part of the harm reduction here in the prevention. I know we had talked about it before, but then to be stabbed 5 times, not being able to get disability because the judge doesn't believe your shrink that there's anything wrong with you because you've done a 501c3 because it's about the only thing you can do. I think it comes a time now that we need to really start listening to the needs of the family members who have suffered a loss because of what the pharmaceutical companies have done. And it's a complete triple slap in my face. And I'm going to speak for me because I don't want to speak for anyone else on this, to see our $1.2 billion, to see attorneys get 300 million of those dollars. I have not seen anything. I'm seeing people die here right and left, and it's kids. It is so many kids. Nothing is being done. Absolutely nothing is being done for our kids. Now we've got, on top of everything else, we've got this chaos with the anti-Semitism in the schools, the kids suffering, not being able to go to schools. It's just such a, I can't even think of the words I want to say right now, but it is really, really frustrating. It's disappointing. It's upsetting. And I'm so upset right now. I'm so upset. Take into consideration our kids that have died. We sued because of them. I know there's so many struggling, but give us an inch. Give us some little inch. That is all I'm asking for.
Thank you for your comment, Debbie. I appreciate you speaking up today. And sharing your perspective for our public comment period. Ms. Rodriguez, do we have anybody else for public comment today?
Chair Johnson, I do not see anybody else indicating that they would like to provide public comment at this time.
Okay, thank you for that. With that, we're going to move on to agenda item number 3, where we will review and approve the minutes from our March 28th, 2024 Prevention Subcommittee meeting. Thank you to the SEI team for getting this out to our committee members for review. As the committee members have had a chance to review these, I would entertain a motion to approve the meeting minutes from our March 28th meeting.
So moved.
This is Debbie Nadler. I'll second it.
Fantastic. Didn't even have to call for a second. Motion by Senator Dunyate and seconded by Debbie Nadler. All in favor, say aye.
Aye.
Any opposed? I think that's our unanimous vote there with the folks today. Motion carries with an approval for the minutes for March 28th. With that, we have some pretty fantastic presentations here today. So I am going to move on to the first one, which was a recommendation from one of our subcommittee members to have a presentation on some of the more recent data. So a big thank you to Dr. Lynch from UNR Larson Institute for coming today to do a presentation on statewide data.
Dr. Lynch, should I stop sharing so you can share your PowerPoint?
Yeah, that would be great. Thank you so much.
Mm-hmm.
All right. Okay, can everyone see the presentation? Awesome. Great. Well, thank you so much to the subcommittee for inviting me to present kind of a statewide data update as it pertains to some of our opioid-related data. My name is Taylor Lynch, and I am one of the assistant directors at the Larson Institute for Health Impact and Equity within the UNR School of Public Health. Quick disclosure here, I do just want to quickly acknowledge that the Larson Institute team does receive sub-award funding to carry out certain overdose data to action surveillance, prevention, and evaluation activities from the Nevada Department of Health and Human Services through the Centers for Disease Control and Prevention. All right, so I'm not sure if everyone is familiar with the CDC's Overdose Data to Action, or OD2A, as it's commonly abbreviated, program. But this is a federal program that supports state, territorial, county, and city health departments in obtaining more comprehensive data to enhance our overdose surveillance, reporting, and dissemination efforts, really in an attempt to better inform our prevention, early intervention, treatment, harm reduction, and other efforts. And so today I'm going to be talking about some of our OD2A related data that I have had the pleasure of working with for the last year or so. I think we have some really interesting data that I look forward to sharing with the committee to provide an update about kind of where things have been the last few years and where we're at today. So just to provide a quick overview of the types of data that I'm going to be providing an update on, there's 3 sort of main sources of data that I'm going to be talking about today. The first, I'm going to be talking about some of our what we call syndromic surveillance data, which is data that we receive in near real time from our emergency departments and certain urgent care centers across the state. I'm going to be talking about some of our mortality data through a system that we have called the State Unintentional Drug Overdose Reporting System, or SUDRS. And then I'll just provide a brief update on some of our recent Prescription Drug Monitoring Program, or PDMP, data. In regard to special populations, I think across all of these different data sources, some of the data sources will include some information for some of these specific special populations of interest, obviously including people who use substances. I think with the SUDRS data, we have some information regarding veterans and people who are incarcerated. Across all of our data sources, we have information about those living in rural communities. And whenever possible, I did my best to provide breakdowns by age and race and ethnicity. All right, so I'm not sure how the group typically operates with presentations, but I'm happy to answer questions as they come up or to wait till the very end, whatever the committee prefers. Either is totally fine with me. But I want to start by providing just kind of an overview of the first data source that I'm going to be providing an update on, which is our syndromic surveillance emergency department data. So the data that I'm going to be presenting to you all here first is data from what we call the National Syndromic Surveillance Program, or NSSP. This is essentially data that we receive from our emergency departments regarding overdose-related emergency department encounters. I just want to, before we get into some of the data, provide just a quick overview of some of the limitations of these data. So these data are very, very timely. I should start by saying that that is a strength of these data. We typically receive this information within 24 hours of the patient encounter. But because of this, some of the data may be incomplete or missing. There are changes in the reporting facilities and the data that they report over time. These are typically overdose encounters that are not confirmed by toxicological testing, just because of the timeliness of the data. And the overdose visit numbers for different substances, which I think we'll look at some of that, are not mutually exclusive. I do want to quickly acknowledge, and I think this presentation will be made publicly available at some point, but we do publish monthly reports with these data on our opioid response website, and I've provided the link to that here. So dating back all the way to September of 2020, we publish a total of 6 monthly reports with these emergency department data. Okay, so to orient everyone to the first figure that I have here, essentially what I'm showing on this slide is the number of suspected all drug, opioid, heroin, and stimulant-related emergency department overdose encounters in Nevada. And I show a total of 3 years. 2021 is shown in green, 2022 is shown in the reddish color, and then data from 2023 are shown in the orange color. And so as you can see, if we focus first just on the all drug overdoses, from 2021 to 2023, we did have a pretty steady increase in the number of emergency department encounters. In 2023, we had nearly 11,000 emergency department encounters that were related to some type of drug overdose, which is an average of around 30 per day across the entire state. We did see increases in opioid-related overdose encounters. So specifically now looking at ICD codes related to opioids, we saw a very similar pattern to what we saw with the all drug overdoses, which encompasses any sort of drug-related overdose. We, over the course of 2021 to 2023, saw a pretty steady decrease in the number of heroin-specific overdose, emergency department overdose encounters, while the emergency department overdose encounters specific to stimulants like methamphetamine, for example, remained relatively constant over the 3-year period. So there's a lot of information going on in this slide here, but I'll do my best to just provide kind of a very quick overview of what sort of are the main takeaways from this information. So what I have shown here is a quarterly breakdown of our overdose counts in emergency departments, as well as rates expressed per 100,000 population for suspected all drug overdose emergency department encounters. And you can see here, there's a couple of different columns of data that are provided in the table. We have statewide data, and then we have some kind of regional breakdowns shown here. We have data specific for Clark County, data specific for Washoe County. And then we have three sort of rural regions. We have a northern rural region, which I have a footnote here, but this includes Carson City, Lyon County, Douglas County, Churchill County, and Story County. We have a southern rural region, which includes Mineral, Esmeralda, Nye, and Lincoln County. And then our rural region includes data from Humboldt, Pershing, Lander, Eureka, Elko, and White Pine counties. And these are in alignment with our state's behavioral health regions. And so what you can see here, if we look just at the statewide data, again, I have data from all of 2023 broken down into Q1, Q2, Q3, and Q4, as well as data from the first quarter of 2024. And you can see that sort of on a quarterly average, so for each sort of 3-month period, we average around 2,800 emergency department overdose encounters. This comes out to a rate on average of around 87 or 88 per 100,000 population. Most of these numbers, just due to our, the population makeup of our state, do come from Clark County and Washoe County. Those represent a little bit more than I think 90% of our emergency department overdose encounters. You can see that the rates are typically highest in Washoe County. What we've seen over the last couple of years is just kind of generally speaking, the emergency department overdose encounters are slightly higher in Washoe County compared to Clark County. And then not surprisingly, just due to the lack of emergency departments in some of our rural regions, the overdose encounters there are lower. And then I wanted to provide a couple of demographic breakdowns for some of the recent data. So I think the next 3 slides here show the age, biological sex, and race and ethnicity of these emergency department encounters for the fourth quarter of 2023. So this is just looking at data from October to December of 2023, but this is pretty representative of what we see across the entire year. You can see the highest percentage of visits in regard to age are among 25 to 34-year-olds. And when we combine that with the second highest category, 35 to 44-year-olds, that represents almost half of our emergency department suspected overdose encounters that we see across the state. So as it relates to biological sex, there is a slightly higher proportion of suspected overdose emergency department encounters among males, 55% of all visits, compared to females, around 45% of all visits. And then for race and ethnicity, I have kind of 2 pieces of data that are being shown here. So first, if we just kind of focus on the pie chart that I have shown, this represents the percentage of visits by different racial and ethnic groups. And then I also have the rates per 100,000 population, which we'll talk about second. So in regard to American Indian and Alaska Native persons, they make up 1.3% of these emergency department encounters for overdose. For the Asian and Pacific Islander population, 2.6% of all visits. 21% of all visits were among the Black or African American population. Hispanic, 14.1%, and then white, 52.1% of all suspected overdose emergency department visits. I do want to note that even though the white population sort of makes up the largest percentage of these overdose emergency department encounters, when we convert these to rates to get sort of a more accurate depiction of what's going on within each of these racial and ethnic groups, as you can see here, we actually see that the highest rate per 100,000 population is among the African American and Black population, followed by the American Indian, Alaska Native population, the white population, and then Hispanic and Asian or other Pacific Islander, which had the lowest rate per 100,000 population. And then I think the final slide I have for the syndromic surveillance data here, this shows the monthly number of suspected all-drug overdose emergency department encounters in Nevada among adolescents. So this is looking specifically at those aged 12 to 17. You can see here, these are monthly counts or monthly number of encounters that we see for each of the months in 2023. And you can kind of see that these data sort of fluctuate month by month, but on average, we see somewhere around 52 to 53 emergency department encounters among adolescents each month in Nevada. So before I move on to the next data source, just to provide a quick summary here of the syndromic surveillance data I just presented. What we've seen over the last couple of years is a continued increase in overdose-related emergency department encounters. This could be due to a multitude of factors, which include, a true increase in the number of overdose encounters, but also greater awareness among providers about sort of things to look for as it relates to overdose encounters, as well as an increasing number of facilities that are reporting into this system. Sort of in general, what we've seen over the last year is that the highest percentage of visits are among males as it relates to biological sex, and then for age, those aged 25 to 34. And we see the highest rate of visits as it pertains to race and ethnicity among African American and Black persons. All right, so next I'm going to talk about data from our state unintentional drug overdose reporting system, which we call SURG, which is a component of the Overdose Data to Action program. SURG is very comprehensive data that we have on unintentional or undetermined drug overdose mortality. Their data for SURG is ascertained through 3 different sort of data sources, which include death investigations, toxicology reports and testing, as well as information from death certificates. There are some limitations with these data, as you'll see here in just a second, the largest being sort of a lag in the final kind of approved and quality assured data that we have access to. And then just because of the comprehensiveness of these different data sources, sometimes we have more missing or incomplete data than we'd like to have, although this is getting better over time. So for today, unfortunately, I'm only going to be presenting data from 2019 to 2022. We're hoping to have our finalized data for the first half of 2023 ready and available soon. But at this point, our state's public-facing dashboard, which I provided the link to here, only has data from 2019 to 2022. All right, so this first slide here, this shows just the number of unintentional or undetermined drug overdose deaths in Nevada that are identified through SURG for each of the years from 2019 to 2022. And so unfortunately, as you can see here, we have seen an increase in the number of unintentional drug overdose deaths that we've seen in the state of Nevada over the last 4 years. So in 2019, there were 510 unintentional or undetermined drug overdose deaths that we identified through SURG. This jumped up to 788 in 2020, dropped a little bit to 736 in 2021, and then we saw another jump back up to 836 deaths in 2022. And so this slide is kind of more or less showing the same information. This is just expressed as rates per 100,000 population to account for changes in our population over time. So I think the big takeaway here is that the rate of unintentional overdose deaths was 16.4 per 100,000 population in 2019, and that has increased up to 26 per 100,000 as of 2022. So this slide shows the SURG data sort of stratified by those different regions in the state. And so I'll draw your attention here to just a couple of key takeaways, as I know there's a lot of different numbers that's presented on this slide. But I think the key takeaway is that if you look at this column that says total overdoses, this is the total number of overdose deaths in each of the different regions. There were 505 overdose deaths in Clark County in 2023, 237 in Washoe County in 2023, and then for the northern rural region, 47, for the rural region, 29, and then for the southern rural region, 14. And when we convert these to rates, when we express these as rates per 100,000 population, if you just look at the crude rate column here on the far right, so even though we see the highest number of total overdoses in Clark County, due to the population size, the rate of overdose deaths is actually highest in Washoe County by quite a substantial margin. So you can see here that the crude rate is 47 overdose deaths per 100,000 population in Washoe County. The next highest is in the rural region with a rate of 29 per 100,000. And then Clark County actually has the lowest rate at 21 per 100,000 population. So I'll skip through this slide very quickly. This just shows the rate of drug overdose deaths stratified by region. Essentially, it's just kind of showing us that, we've seen the highest rate in Washoe County since 2019, and it's continued to steadily increase. We do see quite a bit of fluctuation in some of the rural areas just due to the low number of overdoses that we see in those areas. And we've seen an increase in Clark County as well. But again, the highest rates that we see are in Washoe County. So this slide here shows some demographic characteristics of the 836 unintentional or undetermined drug overdose deaths identified through SURG in Nevada for the year 2022. And so what I just want to draw everyone's attention to here is just some of the rates for different demographic groups. So when we look at age group, for instance, we can see that the highest rates really that we see are sort of among 4 age groups, and it's really the 30 to 39 year olds, 40 to 49, 50 to 59, and 60 to 69. They all have rates between 40 and 44 per 100,000 population within those age groups. We do see that the rate is a little over twice as high for males compared to females. So there were, in 2022, there were 570 deaths among males, 266 among females. And then when we look at race and ethnicity, there's 3 racial and ethnic groups that sort of have higher rates than the remaining racial and ethnic groups. And those you can see here fluctuate between 33.4 and 37.0. And that is the non-Hispanic, Black, or African-American population, the American Indian or Alaska Native population, and then the non-Hispanic white population. So with the SURG data, another sort of, category of information that's collected through the SURG program is circumstances surrounding the unintentional overdose. And so essentially what this slide is showing here is the different circumstances that are measured and what percentage of the overdoses have those circumstances. So for example, if we start with the evidence of substance use, you can see here that there 68.1% of the overdose deaths had a history or evidence of previous substance use. About 60% of these 836 overdose deaths occurred in a household. For almost 44% of these overdose deaths, there was a bystander present. Naloxone was administered for about 20% of these overdose deaths, or about 1 in every 5. And then you can see in regard to homelessness, about 10.5% of the overdose deaths, a history of a previous overdose for about 9% of the overdose deaths, served in the US military, 8% of the overdose deaths, et cetera. And then I'll also just note that 22% of these overdose deaths, there was a mental health diagnosis that was reported as well. All right, and then I know there's a lot of data going on this slide, but again, I'll just try to draw your attention to kind of the key takeaway from this slide. So this shows some different substances contributing to death among the unintentional or undetermined overdose deaths in Nevada from 2019 to 2023. And so I'd like to highlight just a couple of things on this slide. So we'll start by looking at this first sort of cluster of bars here, which shows the percentage of overdose deaths that involved any opioids. You can see that it's sort of remained relatively constant over the course of 2019, 2020, 2021, and 2022. Close to around 2/3 of all deaths involve sort of any opioid. As it relates to methamphetamine, which is a stimulant, we see that, close to about half of all of these overdose deaths, methamphetamine was listed as a contributing substance to the death. And what's interesting is between 2019, shown in green, and 2022, shown in blue, we've seen that the percentages of deaths where heroin was a contributing substance has sort of steadily declined. But not surprisingly, we've seen that the percentage of deaths where illicitly manufactured fentanyls were a contributing substance has sort of dramatically increased over the last 4 years. So in 2019, only 15.3% of the overdose deaths listed illicitly manufactured fentanyls as a contributing factor, and that has jumped up to just under 44% of all overdose deaths in 2022. All right, so a quick summary of the SURG data that I just presented. So over the last 4 years or so, we've seen an increase from 510 unintentional or undetermined overdose deaths in 2019 up to 836 in 2022. We saw the highest rates for Washoe County compared to other areas. The rate was about twice as high for males compared to females. Compared to all of the other age groups, we saw that sort of the age groups from 30 to 69 had the highest rates. And then in terms of race and ethnicity, again, we saw the highest rates for African American or Black persons, American India or Alaska Native persons, or white persons. And then again, just to reiterate the point as well, that we saw an increase in the percentage of deaths that involved illicitly manufactured fentanyls over time. 15.3% of deaths in 2019, up to 43.8% of deaths in 2022. All right, and then the final data source that I'll be just giving a quick update on is our Nevada Prescription Drug Monitoring Program, or PDMP data. And so this data essentially tracks prescriptions in the state of Nevada. And we can kind of look at how these data have changed over time. So again, there is a public-facing dashboard for these PDMP data that's updated by the Office of Analytics, I believe, on a monthly basis. But just to kind of highlight sort of an overall trend that we've seen over the last 7 years, which is sort of the time period that the dashboard encapsulates, this shows just kind of the total prescription counts and prescription rates per 100,000 population from 2017 to 2024. And what you can see is that we've had sort of steady decreases in the total number of prescriptions that we've seen across the state during that time period. If we just kind of focus in on data from the last 5 years, again, this is statewide data. You can see here that we've had, again, sort of a steady decrease. This slide here shows the annual number of opioid prescriptions. So these are prescriptions specific to opioids in Nevada from 2019 to 2023. In 2019, there were 1.7 million opioid prescriptions statewide, and that's dropped to 1.35 as of 2023. And then I wanted to also provide just kind of like a regional breakdown in terms of how prescription rates vary by region in the state. And so this slide here shows the average monthly prescription rate per 100,000 population in Nevada by those behavioral health regions just for 2023. And so again, this is sort of a monthly average rate. So statewide, a monthly average prescription rate of 35 prescriptions per 100,000 population. You can see pretty distinctly here that the northern rural region and the southern rural region have pretty significantly higher rates of opioid prescriptions compared to Clark County, Washoe County, and those remaining rural counties. So to summarize the PDMP data, we've seen a pretty steady decrease in opioid prescriptions over time. Just between 2019 and 2023, we saw about a 20% decrease in the total number of opioid prescriptions over that specific time period. And again, as we just saw in the previous slide, the average monthly prescription rate per 100,000 was highest in those northern and southern rural regions. The northern region, again, encapsulates Carson City, Lyon County, Douglas County, Churchill County, and Story County. And for the southern region, Mineral, Esmeralda, Nye, and Lincoln counties. All right, so just to kind of close out here, I wanted to highlight just a couple of quick points as it relates to what's working well. So I think what's working well sort of from my experience in working with these data is I think our state does a great job of leveraging different data sources to assess and monitor the burden of substance use in Nevada. As you saw from today's presentation, each of these data sources, and I didn't even talk about any of our EMS data, but they all sort of have their different strengths and limitations. But what's really best is when we sort of look at them all together. So again, I appreciate the opportunity to come and present some of these data to you all today. For some of our data sources, again, what's really great is the timeliness of some of these data sources. So As I described earlier, our emergency department data, this is something that we can monitor in almost real time. Again, we typically get these data within 24 hours of the patient encounter. And our PDMP prescription drug monitoring data is updated on, I believe, a monthly basis, which is great as well. There's a lot of impactful interventions going on across the state. And so I just want to acknowledge all of those continued efforts. And we have, as sort of shown by the data, seen some reductions in opioid prescribing as tracked through our PDMP data. So in developing this presentation, I reviewed the subcommittee's sort of recommendations, and I think they're all great. And with that, and sort of looking at the data that I have access to, kind of identified a couple of gaps and needs just as I see it through my lens. Again, just really highlighting, it's always great when we can look at several different data sources together. I think they each have their own strengths and limitations, and it's really helpful to utilize several of them whenever we can to paint sort of a more complete picture of what's going on. But in terms of general gaps and needs, obviously, some of these things we can do things about, some of them it's a little more challenging, but our suitors data is great and very informative, but there is a data lag. Obviously, the fact that it's June of 2024 and we don't have the 2023 data on our dashboard is unfortunate. I'd love to see improved accessibility of data, not only for public health professionals, but sort of for the general public. And I'll talk about that on the next slide. And then one thing that I've sort of really been interested in and have had some conversations with colleagues about recently is continuing to increase our capacity for doing some drug checking and monitoring the drug supply in real time, which I believe Southern Nevada Health District has done some of this work, and it's super helpful work for monitoring kind of what's going on in real time as it relates to the drug supply, instead of finding out, 6 to 12 months later after we're already seeing deaths. So in terms of recommendations based off of those gaps and needs, I know one thing my team is working on is really trying to improve our organization and accessibility of data. I've seen from other states, I've been browsing around recently and seeing how other states kind of have a centralized hub where data is readily available, even having dashboards, that's kind of like a one-stop shop that shows, some of them I've seen have shown 60 to 70 opioid related indicators and also show kind of trends over time. And I know specifically within my team, one thing that we're trying to do is consider different audiences. So previously, a lot of our materials in terms of our monthly data reports have been marketed towards health professionals, which is obviously needed, right? We need to share these data with doctors and with public health professionals, but we're trying to work on developing some infographics and messages just sort of for the general population or even for people who use substances as well. And then again, I know this is one of the committee's recommendations that I saw in the document that was shared with me, but I'd really just like to advocate for improving our state's capacity for monitoring of the drug supply. I know that other states have done this with great success and are able to sort of test syringes and other things in real time to sort of find out what's going on with the drug supply, which can really help us to target our prevention efforts more appropriately. And then again, just a couple of references here. So the Nevada Overdose Data to Action website has all of our monthly syndromic surveillance data reports publicly available, and we publish those on a monthly basis. We also publish like some quarterly reports and kind of some other special reports there, but the Nevada Office of Analytics also has a data dashboard and reports catalog, many of which are related to opioid data and substance use. So the suitors data dashboard that I presented today is publicly available. There's some really great tools where you can filter out by different substances and areas and years. So I highly recommend everyone check that out as well. And then, yeah, if there's time, I'm happy to answer any questions. If not, please feel free to contact me. I'm happy to chat over email or over phone or Zoom with anyone who might have any questions. And yeah, thanks again to the subcommittee for your time. I appreciate it.
Yeah, thank you so much, Dr. Lynch. We really appreciate a comprehensive overview you shared today. I think we have time for maybe a couple of questions from the committee. Emma, would you say about 3 minutes or so of questions? All right, terrific. Ms. Nadler, go ahead with your question for Dr. Lynch.
Thank you so much. That was an awesome presentation. I know we all really appreciate it. I do have 2 questions to ask you. I'll make them real quick. In the beginning, when you were talking about the hospital reporting data that you're getting, is this something that's for overdoses? And I assume when you're talking about overdoses, this is, when you're talking about overdoses, are you talking about the overdoses where the children have lived in those stats
Yeah.
that in the very beginning?
Yeah, thanks, Ms. Nowler. That's a great question. So yes, for that emergency department data, those are non-fatal overdoses, correct?
Okay, so is it required of all hospitals to send you that data, or is it just certain hospitals that are sending you that data?
Yeah, so all of the emergency department facilities are, last time I checked, I think it was all in Nevada, are a part of the syndromic surveillance network. And we not only use that for overdose related data, but we use it to track communicable and non-communicable diseases as well. And we're even starting to use it for monitoring things like adverse childhood experiences and exposure to violence and abuse and neglect. So yes, I believe our compliance for reporting is really, really high with those data. I'd have to check to confirm that, but
Yeah, I'm just curious if it's mandatory, because if not, I would think it should be, and I think it's a great thing you're doing. And then my second part of my question is, on the reports of the heroin and the meth, I see our numbers have skyrocketed, not surprising in the meth. When they OD for meth, according to your report, is it only meth in their system, or is it a combination of other drugs? Like, is there a way to distinguish?
yeah, that's a great question. So oftentimes there are multiple substances that are involved, and on that suitor's dashboard, there is an option to kind of click that specific like multiple substances. I do believe that is fairly common in what we see in those overdose deaths, that there often are multiple substances that are involved.
Thank you. And sorry, last question. Are y'all doing anything with the new drugs that are coming in? I see we're getting hit hard with xylazine. Is that included in any of these factors, or is it not, because we're not up to date for 2023? Or
Yeah, as it relates to the suitors data, I'll have to check with the analyst at the state and see. And I believe that the xylazine's been detected in Southern Nevada, so I'm not sure if Brandon or someone else has any context to provide on that, who might be able to answer it better than I can.
thank you. And it would, sorry, I'm sorry. I have one last question. In the hospitals, when there is an overdose, do we have rapid testing for fentanyl? Or would that be a Brandon question?
Yeah, I'm not sure if anyone can answer this better than me. I am assuming that it's available in some facilities. I'm not sure how often it's being used, but I would assume that it's definitely available in most facilities.
Okay. All right. Thank you.
But again,
Sorry.
I'm not totally sure if anyone has a better answer.
Yeah, thank you, Ms. Nadler, for your questions, and Dr. Lynch for your answers. I just had, if we, I'm going to use chair privilege to take one more minute. I had just a couple of quick questions, and then we'll get to, I know our next agenda item is Mr. DeLisi's presentation. Maybe he can weave in some answers to your questions, Debbie, if he has them. A quick question, Dr. Lynch, so with the syndromic data, do you think, I noticed the rise in hospitalizations that you mentioned, and I was wondering, one of the hypotheses that wasn't mentioned was about naloxone, and I was wondering if perhaps one of the factors could be more naloxone out in the community, meaning more non-fatal. Like, could that result in potentially more hospitalizations? Is that a place that might show up?
Yeah, no, I think that's a great point. And it is something that I hadn't thought of, but definitely, yeah.
Okay. And then I know you mentioned the suitors data lag. And if you mentioned it, I apologize, I missed it. What are some of the factors that that contribute to the length of
Yeah.
time that we wait to receive the data?
So a lot of it is quality control. So there's a lot of like internal quality control procedures that are mandated. So a lot of this data is collected by the coroner's offices. I think they're called like the regional, I forget the exact name, but we have one in Southern Nevada. We have one in Northern Nevada. They work with the folks at the CDC on data abstraction issues, and then because this is sort of a nationally funded program, the CDC works to make sure that the data is sort of standardized across all states, so that they can, present the data all together in like a national dashboard, and so that comparisons can be made across states. So I'd say the biggest sort of lag in data is just kind of like quality control, and ensuring that, we're meeting all of the requirements for all of the variables so that our data is comparable to other states.
Okay, that makes sense. It is
Yeah.
unfortunate, but the quality piece makes sense. It's often a trade-off in my experience. And then I think kind of my last question about the PDMP data source. Every time I've had the opportunity to look on that website, I get a little thrown off because it seems like there's a rate for prescriptions of like 1,000 or something like that, and then a different rate for people. I was wondering if you could explain that part of the presentation or the data uh, to someone like me who's not a data epidemiologist.
Yeah, no, it is. They do present what it is kind of confusing on the dashboard. They present rates per 1,000 for certain substances and then per 100,000 for other substances. I've noticed at times too that the data will just like, there will be random spikes in the data, and then a month later it's fixed and isn't there anymore. So I'm not sure what the cause of that is. I was actually just recently connected with someone who works with that data and I think updates the dashboard. So I'd be happy to reach out to them and sort of get more information about like what goes into putting this data into the dashboard, and figuring out kind of the best way to interpret it. But we've just always leveraged the monthly sort of opioid prescription rates in terms of just the prescription counts. And then we actually kind of calculate the rates on the back end ourselves just to make sure that they're correct, since we have noticed that there's been changes sometimes.
Okay, fantastic. If you wouldn't
Yeah.
mind reaching out to your contacts and following up with Ms. Rodriguez for some clarification, I think that'd be helpful for our committee, if you don't mind.
Yeah, sounds great. Happy to do that.
Thank you. With that, thank you again, Dr. Lynch, for your presentation. I really appreciate your time today and fielding questions from our committee. I'm going to move on to agenda item number 5, which is a presentation from the Southern Nevada Health District. Brandon DeLisi, who's a senior epidemiologist there, will be presenting. Mr. DeLisi, the floor is yours. And if you're speaking, you may be on mute.
Everybody, can you
Now
see
we
the
can hear
screen?
you.
Full
Yeah.
screen? I take it? Perfect. So my name is Brandon DeLisi. I'm a senior epidemiologist at the Southern Nevada Health
Oh,
District. I'll be giving.
sorry. Brandon, we're seeing the notes, not the full screen.
Oh,
Apologies
interesting.
for
It's
interrupting.
popped. I have 3 monitors here, so it must be popping on the other one. Interesting. So let me share. Okay.
Brandon, if it's helpful, I can also share my screen since I
Okay,
have.
let me see if I can do this.
Okay.
I don't think it'll be that hard. Maybe. Okay, and then I think it's, you still can't see it, right? That's so funny. It pops up on my second screen, but not on my first screen. I wonder how I can control that. But if Emma, if we want to go the route where you can share.
Yeah, absolutely.
Thanks for your flexibility.
And Brandon, just so you know, we did some work to remediate the slides. I think they should still look pretty similar, but in case you're like, that looks like a slightly different color, it's because making things ADA accessible. So
That's fine.
Let me share my screen. Okay, can everybody see the right slide?
Yes, I can. Thank you.
Yes.
Right.
Okay, so let's get started. So again, my name is Brandon DeLisi, Senior Epidemiologist from the Southern Nevada Health District. I will be going over some fatal and non-fatal opioid overdose indicators. And so full disclosure, I listed a lot the grants that I'm under. So I do lead a SAMHSA FR CARA grant. I provide in-kind to the CDC's Overdose Aid to Action grant. And then I also provide in-kind to the BJA's COSA grant as well. So just letting you know that I am a part of that funding stream. And so just following the template of the slides, and as for an introduction, so just drug overdose surveillance is a critical tool for health departments, local and state, providing essential data to drive effective public health responses, improve community health outcomes, shape policies, and address root causes of impacts of the overdose crisis. And so key issues that are being addressed, so just 3 quick bullet points. Drug overdose surveillance allows the Southern Nevada Health District to quickly identify increases in drug overdoses, clusters, hotspots throughout Clark County, enabling prompt interventions. We can identify new or emerging drugs, for instance, xylazine, and then we can research into the causes, patterns, and the effects of drug overdoses, contributing to a deeper understanding of the epidemic. And so while I do touch upon the special populations that were provided, I don't specifically go and stratify and provide data on those. So just for a general overview, I'm not going into specific populations. And so these are some of the indicators that I'll be talking about. So I also like Taylor, want to go over some of the pros and cons with these data sources. So the first is EDRS, our electronic death registry system. So this is using our Clark County death records. So we have confirmed drug overdose deaths. They're captured, we can analyze them. The great thing about these data is they're very rich, but there's a 3-month delay into getting them. And so the next data source I want to talk about is Essence, which is our syndromic surveillance system. So we use that to monitor real-time trends in ED emergency departments using chief complaint information. So the good thing about syndromic surveillance, it allows for the detection of disease outbreaks, drug overdoses earlier than traditional surveillance methods. But since it's real time, the data quality is not very high since there's a lot of data variability and incomplete data present. And so the last data source that I'll be talking about is ESO. ESO is a program that captures EMS data and links it to hospital outcome data. I'm able to pull non-fatal opioid overdose data using ESO. ESO is real time, but it's limited in the number of variables that can be used for analysis. So when I go over those data, you'll see, unlike our death data, there'll be much less variables that I can break down due to the amount of variables present. And then the other indicators I'll talk about as I present them. So some of the other ones are naloxone indicators. I have some HIDA data that I'll be pulling from, and social vulnerability index data as well. So these are the fatal drug overdose indicators that I'll be talking about. So let's start with the first one. So this is the age-adjusted overdose death rate involving any opioid per 100,000 Clark County residents from 2018 to 2023. And so during that time period, the death rate increased 82.19%. Yeah. So looking at the age-adjusted overdose death rate involving heroin per 100,000 Clark County residents, during this time period, the death rate decreased 45.34%. Yep, that's perfect. So moving on to fentanyl, synthetic opioids. So this is the age-adjusted overdose death rate involving fentanyl per 100,000 Clark County residents from 2018 to 23. So during this time period, the death rate increased 544.68%. So a big jump when it comes to fentanyl involved overdose deaths. Next, perfect. And so looking at prescription opioids, the ICD-10 code is specifically other opioids, but it captures most semi-synthetic opioids. So just for a label, I put prescription opioids. So looking at this death rate during this time period, we've seen prescription opioid deaths decrease 37.5%. Next. So now going forward, the majority of the presented data will focus specifically on the year 2023, unless otherwise noted. So the top 5 zip codes with the highest opioid overdose death rate in 2023 are 89101, 89145, 89169, 89104, and then 89119. So these geographic regions appear throughout this presentation. I do have quite a bit of maps. Next. So these are where the zip codes on the previous slide are located, with the addition of a few more. So again, these are the zip codes with the highest opioid overdose death rate. So this is a heat map of fatal opioid overdoses using Clark County residential address for 2023. Overdose clusters are located downtown, Washington and H Street, and then the UNLV area, which is Flamingo and Paradise. Next. Oh, perfect. You did it. So this is a heat map of fatal opioid overdoses using injury location. So in 2023, these clusters are located downtown around 13th and Stewart, the Arts District area, and then just north of UNLV, the Flamingo and Paradise region as well. And many of us are aware that overdose deaths are not usually caused by one drug or substance. So this is a cross tabulation of fatal drug overdoses involving counts, involving multiple substances among Clark County residents in 2023. So you'll see that fatal drug overdoses involving both methamphetamine and fentanyl exhibit the highest frequency. This is a trend that I've been noticing this past year in 2023 and 2024, and it underscores just the need to educate more and let people know what we're seeing in the drug supply and what people are dying from. Next. So the last slide got me to think about how the stimulant and fentanyl combination has changed over the past decade. So this is a proportion of fatal fentanyl overdoses co-occurring with methamphetamine and or cocaine. And it's been on a consistent rise annually from 2017 to 2023. So by 2023, stimulants were involved in 55% of fatal fentanyl overdoses, which is an alarming trend. The next few slides will go over opioid overdose death descriptive statistics among Clark County residents for 2023. The race ethnicity with the highest opioid overdose death rate occurs among people who are Black, closely followed by people who are white. The gender with the highest opioid overdose death rate occurs among men. And the age group with the highest opioid overdose death rate occurs among 35 to 39-year-olds, followed by 30 to 34-year-olds. Next. The majority of fatal opioid overdose deaths occur in homes, followed by outdoors, public area, and then other residents. So as you can see, the clear majority occur at individuals' homes. Next, perfect. So this table includes descriptive data comparing deaths in 2023 versus 2022 for 3 substances. Those substances are all opioid, fentanyl, and then methamphetamine. So the age group 60 to 64-year-olds, 50 to 54-year-olds, and then 45 to 49-year-olds experience a notable increase in fentanyl-related overdose deaths. Female overdose deaths decrease across all 3 substances. Female overdose deaths decrease markedly for all opioids, roughly 20%, and methamphetamine roughly 25%. Females also have a higher percentage decrease in overdose deaths, just indicating some potential gender-specific patterns, some intervention effectiveness. So there's more research that needs to be done to see why that's occurring, but it's a trend I've been noticing over the past year. Next. So this is a figure displaying opioid overdose mortality by hour and day among Clark County residents in 2023. The more red and darker red the color, just the higher the frequency of the deaths. And so Saturday and Sunday have the highest frequencies of opioid overdose deaths. The hour with the highest number of deaths for those 2 days is 2 p.m. Tuesday has the lowest number of opioid overdose deaths, and the day and the hour with the highest count of opioid overdose deaths occur both on Saturday and Sunday at 2 p.m. So it's really important to note that it just may take many hours before an individual is pronounced dead. So when you see these data, it just doesn't mean that's exactly when they died. It's when they're certified dead. Next. And then using data from our death record data, EDRS, I conducted a logistic regression to calculate odds ratios for opioid overdose deaths. I analyzed demographic characteristics to determine which ones remain independently linked to opioid overdose deaths. This analysis found that non-white individuals had a 43.8% lower odds of fatal overdose compared to white individuals. And then females had a 39.1% lower odds of fatal overdose compared to males, while those who were not married had a 83.5% higher odds compared to those who were married. So those are some of the things that we can look at, these associations. They provide valuable information to the population that we're serving. Next. So this is the last slide for fatal opioid overdose indicators. I was curious to see if there was an association between drug seizures and overdose fatalities, specifically fentanyl overdose fatalities. So I looked at fentanyl deaths and then Nevada Hydra seizures. This is a linear regression, and it indicates that the number of fentanyl seizures is associated with fentanyl-related deaths. So again, this means that there is a significant association between the two, and then knowing one can inform the other. For instance, if fentanyl seizures go up, we can infer that fentanyl overdoses will also go up. However, while seizures may contribute to the variations of fentanyl-related deaths, there's a lot more to it, and more research and consideration of other factors are needed to fully understand this relationship. But it is a valuable piece of data that we can use for just tailoring our outreaches and just understanding how these drug overdose deaths are fueled. Next. So we're going to move on to non-fatal opioid overdose indicators. The next two slides are using Essence data. So Essence, if you recall, monitors real-time trends in ED utilization using chief complaints. So using Essence, the individuals who had the highest frequencies of opioid overdose ED visits were men and people who were white. Next. And people who were non-Hispanic, and then individuals aged 25 to 34, 35 to 44, and 45 to 54. And these, the only difference between what I just presented and other slides, I'm using frequencies with Essence data and not rates. So just interpret with a little bit of caution. And then, great, we're on ESO now. Some of these slides look the same, so I'm just trying to double check here. So the next few slides use ESO data. So trying to remember, ESO is that program that captures EMS data and links it with hospital outcome data. So using ESO, the individuals who had the highest non-fatal opioid overdose rate were individuals who resided in the city of Las Vegas compared to other Clark County cities, men, and next slide. Yeah, and then individuals who were American Indian, Alaskan Native. Great. These figures, these display the time and day of the non-fatal opioid overdose. So among Clark County residents in 2023, Tuesday had the highest frequency of non-fatal opioid overdoses. The hour with the highest number of non-fatal opioid overdoses throughout the week was 3 p.m. And then Sunday has the lowest number of non-fatal opioid overdoses. Next. This is a heat map of the non-fatal opioid overdoses using injury location among Clark County residents. And then also there's non-residents in here as well. Just think tourists, individuals who are here temporarily but are not residents. Overdose clusters are located downtown, Rainbow and Charleston, that Naked City area, the Arts District Naked City area by the Stratosphere, and Boulder Highway. Next. So using ESO, I did an odds ratio using ESO for non-fatal opioid overdoses. So I analyzed demographic characteristics to determine which remain independently linked to non-fatal opioid overdose. So after running the logistic regression, the analysis yielded that the odds of non-fatal opioid overdose are 61.4% lower for women compared to men, and the odds of non-fatal opioid overdose are 50.9% lower for individuals not residing in the city of Las Vegas. So cities like Henderson, North Las Vegas, et cetera, holding all variables at a fixed value. So again, typically I'd include more about variables in the analysis, but ESO has very few that are complete, unfortunately, but I'm at least happy that I have those data. Next. So moving on to social vulnerability index indicators, or SVI data. Next. So the CDC created a social vulnerability index variable, or SVI indicator. So it ranks census tracts on 16 social factors, which you can see right here, including unemployment, racial, ethnic minority status, disability. It quantifies them into one statistics. It ranges from 0 to 1, and the higher the value is to 1, the greater the vulnerability. So we like to use that and overlay that with our opioid overdose death data to really pinpoint some unique areas in the valley. Next. So this is what SVI, this is what SVI looks like here in Clark County, with the graduated colors in the census tracts corresponding to corresponding to the overall SVI ranking. So the darker the colors, the higher the SVI ranking. Again, so this is Clark County. Next. And then, so early on in the presentation, I showed opioid overdose mortality zip code maps. So this is a map consisting of opioid overdose mortality, but using census tracts. And then again, the graduated colors in the census tracts corresponding to the higher number of opioid overdose fatalities. But there's a lot of data suppression going on here. There's only so much I can release. We can't release opioid overdose deaths with a frequency less than 5. So these are the only 2 that are left. So now I'm going to overlay this with the map of the SVI, and we're going to see what kind of comes out. Next slide. So yeah, this is a map combining the 2 previous maps together. So this displays counts of opioid overdoses in the 90th percentile alongside overall SVI ranking in the 90th percentile among residents in Clark County. So the census tract with overdose counts and SVI in the 90th percentile is located in that Charleston and Las Vegas Boulevard area, and then going south to Sahara. So this is the one area when we're talking about SVI and opioid overdoses that we should really focus on. Next slide. And this is a correlation figure. So usually there's a lot more data to this. There's only one. So it's that census tract ends in 1200 for those of you who are curious. Next slide. So yeah, let's look more at this population that's in the 90th percentile of both opioid overdose mortality and SVI. So Thursdays across the week are the days with the highest frequency of fatal opioid overdoses. So as a note, these aren't the only 2 days where there's deaths. The rest of the days have been suppressed since they are less than 5. So when analyzing this population, since we don't have a lot of counts, you're going to see a lot more suppression. Next.
Oh, and Brandon,
Yeah.
we have about 5 minutes left, just so.
Okay, I think I have 5 minutes left, so.
Perfect.
Great, so. Yeah, so the individuals who had the highest frequency of opioid overdose deaths were men, people who were white, and the highest proportion of opioid overdose deaths occurred at home. Next slide. Individuals aged 35 to 39. So again, the rest of the age groups have been suppressed since they're less than 5. Next slide. And then now we're on to our last segment, naloxone indicators. Next. So there's a few different avenues in which SNHD distributes naloxone and collects data pertaining to naloxone administrations. The first one is SNHD's, the health district's linkage to action team. So this team conducts a lot of outreach in our community and distributes a lot of naloxone during said outreaches. So these are descriptive statistics of naloxone administrations from naloxone distributed through SNHD's L2A team. So the instances of naloxone usage were most prevalent among residents who were outdoors or on the streets at the time of administration. 91% of all opioid overdose events were reported to be successfully reversed, which is amazing to see. Next slide. And the instances of naloxone usage were most prevalent among residents in zip code 89101. Next slide. 1 to 2 doses of naloxone administered to bring back an individual accounted for 84% of incidents. Next slide. And the individuals who had the highest frequencies of naloxone administrations distributed by the L2A team were men and people who were white. So there is a lot of limitations to these data. Just quickly, there's recall bias, limited sample size, privacy concerns. Just at the end of the day with naloxone data, interpret with caution because we may not be looking at the whole picture. Next slide. So this is looking at another grant. This is a grant that I manage, the FR grant. So we distribute to naloxone to first responders and community agencies and organizations. So I employ a distinct survey to collect overdose information. So these are some of the findings of the grant. The individuals who had the highest frequency of naloxone administrations distributed by FR team were men. 97% of all opioid overdose events were reported to be successfully reversed. Next slide. And the instances of naloxone usage were most prevalent among those who were at a business at the time of the administration, excluding the other categories. So using our L2A naloxone data, where that was mostly used in outdoors in the street, this one is with the highest frequency is business. So depending on the type of group you give naloxone to, you're going to see different outcomes. Next slide. And then the individuals who had the highest frequency of naloxone administrations distributed by our FR team were people who were white. 1 to 2 doses accounted for 88% of incidents. And then also the same limitations that I gave for L2A regarding distribution and administrations can be applied here for our FR and naloxone data. So self-reported data, recall bias, limited sample size, so on and so forth. Next slide. And then these are some of our data gaps. I won't have time to go into them fully, but lack of PDMP data, minimal wastewater data. We only have 2 sites in Henderson. Issues with ODMAP where we really can't query the substance that's involved in the overdose. Health disparity data, comprehensive substance use data, timely data, and data suppression. So those are some of our gaps. Next slide. And then for those of you who just want to kind of look at this later on, I compiled pretty much the meat of the slides in these summary slides. So you can look at this and just look at the demographics for fatal data, and you can see those just with the highest rates, who you should target. So, you know, target men, target individuals who are Black and individuals who are white, as these race groups have much higher opioid overdose death rate compared to other groups. So things like that you can really go into if you choose to. So I have that for fatal data. Next slide will be non-fatal data, and then next slide will be naloxone data. And my time is up. I appreciate it.
Thank you so much for a fantastic presentation, Mr. DeLacy, and really, you know, focusing in on some more detail with Clark County. I know that was also of interest to our committee members. We have a couple of minutes for questions. Ms. Nadler, go ahead.
Thank you so much. That was amazing. Great information. One quick question for you. Are you getting any data from the schools? Are the schools allowed to release any data as far as ODs happening at the schools?
So we do typically get information pertaining to overdoses at the schools. There's not a real formalized mechanism, but I feel like we tend to get that information, and plus I can really analyze the data to see the age groups of the individuals who have overdosed, and then through looking at narratives for different reports, I can derive typically what school that they belong to. So short answer is yes, but there is some nuance there.
And then do you see an increase in the school age overdoses, whether fatalities or non-fatalities? I'm not looking at last year's or the year before's.
Yeah, so we have seen some increases. So in 2022, those overdosing less than 18. So I can say from 2023 to 2022, we saw a decrease, and then 2024 is just, there's not a lot of time that's passed to get that data. So we have seen a slight decrease from 22 to 23. Hopefully, fingers crossed that trend continues to happen.
Exactly. Thank you so much. Awesome job. Thank you.
Thank you, Ms. Nadler, for your questions. I had just a couple questions, if that's all right, Mr. DeLacy. So I know at the onset you talked a little bit about the potential of surveillance systems and mentioned xylazine, and I was wondering if you could talk about some of the novel surveillance or other types of surveillance that your team is doing to identify substances or maybe close some of the gaps that you identified.
Yeah, so the health district, Southern Nevada Health District, through funds for ODTA grant, has a novel surveillance method where we do drug checking through refuse, through supplies that are submitted, no longer to be used by the individuals, but just refuse that are submitted to be tested. And so we have the ability to test the paraphernalia, the refuse, to see what substances are on them. So it's really novel in the fact that we can really test the supply that the community is using, our illicit drug supply, and see what's in that. So specifically, and just recently, we were able to detect xylazine, and we were able to do that before our wastewater surveillance picked it up as well. So it's really unique, really novel, and it can be informative as a way to get information to see what hits your community first, faster than other data sources.
Yeah, thank you so much for sharing about that. And I just as a quick point that stood out to me between Dr. Lynch and Mr. DeLacy's presentation, both covered information about residences as a location for fatal deaths. And at least my experience in the community is that many of our interventions have often focused more on unhoused populations, not saying that folks who are unhoused don't need many types of services, but that did really stand out to me as an intersection, and as someone who thinks a lot about policies and interventions with how we reach folks at risk. I wanted to just take this opportunity to kind of make that connection, and for the committee to maybe think about if there are any additional recommendations or other strategies that we might employ to ensure that we have, access for folks, regardless of where they're living from type of residence. Great. Any other questions for Mr. DeLacy today? All right, seeing none, thank you so much for your time and a very robust presentation about the data in Clark County. Really grateful. Thank you both. So we're going to move on to agenda item number 6, and our 11 minutes left here today always feels like a challenge, to planning for our 2024 prevention subcommittee meeting. So wanted to just talk with the committee and attendees briefly about that. So as many of you who tune into this regularly may know, our team at SEI has been working hard to reschedule our May meeting, which was canceled due to lack of quorum, and really working to identify a date that works for subcommittee members and presenters, and hoping to have that rescheduled in the next month or so. So thank you to folks being able to share their availability. We'll be covering and hoping to dive into our recommendations on community health workers. Our August 7th meeting, we'll focus on harm reduction recommendations, and really, following through on the vision to refine many of our recommendations from previous years. So we're looking at thinking a little bit more about that comparison of the Good Samaritan Overdose Act and Maryland Stop Act. I know we'd reached out to Dr. Wagner, who may not be available for this particular meeting, but maybe can share some expertise in advance of the meeting. And then looking for a subject matter expert that could talk through the recommendation on shipping supplies, as well as other harm reduction recommendations. We've requested Chelsea Cheatham as a SURG SME to be at this meeting and help provide guidance. Wanted to open it up to my committee members if there were any other SMEs that we might think about including, or someone who could speak to the shipping program in particular to help us refine that recommendation. Seeing no one immediately come off of mute, I know we had talked about possibly reaching out to Track B Exchange, Impact Exchange, and then maybe potentially, I know Lisa Lee, a former committee member of the SURG, may have some, either be available or have some additional recommendations for an SME to help us weigh in and finalize those particular recommendations. So looking forward to August 7th, I think that is our plan to help begin to refine those for the committee. And then September 4th, this is our last subcommittee meeting before the full SURG meeting. So we'll want to ensure that our recommendations are ready to go so they can be presented at the October 9th meeting and built out for any subcommittee discussion. Specifically, wanted to follow up on the recommendation from our April SURG committee meeting where we discussed the LAPA recommendations, and the one that's on the screen here was the most relevant to SURG. So that's requiring all public high schools to store naloxone on site for responding to overdoses at school and at school-sponsored events. This was considered during the 2021 session under AB 205. And in the data that was gathered by our friends at SEI, they had shared that there were some barriers that were identified by the committee for the implementation of this, in particular as it related to the cost of naloxone being housed at these sites. So I'm wondering if there's an opportunity to strengthen this recommendation, if there's a committee member who's interested in trying to identify ways around the cost barrier for schools, and wanted to open that up for discussion for Senator Dunyate or Ms. Nadler, if you had any thoughts on if this was a recommendation we wanted to add to prevention subcommittee recommendations, and if so, how we wanted to strategize around cost, which was a barrier brought up during when the requirement was considered in previous sessions.
Debbie Nadler for the record. So did we narrow it down to just high schools? Wasn't it middle and high schools, or did we have to go with the high schools? I'm sorry, I don't remember that. Is that what we?
That's a great question. The LAPA recommendation is specifically high schools. And I can go back and look at AB 205. I don't know if it was high schools and middle schools or just high schools off the top of my head. Ms. Rodriguez, are you familiar?
I don't know off the top of my head either.
Would that impact your recommendation, Debbie?
Well, I'm thinking, I'm sorry, my brain is like, I'm thinking of creative ways to get around this because that's something I've been very passionate about. When does the legislator meet again? Because it's those words. It's one word that is stopping this. It says shall. It says may instead of shall. So if we got that one word changed in legislative, then who would pay for that? Us or the state? Like, I'm confused on that. You know what I'm saying? Am I making sense? I just think it's so important. Well, perhaps perhaps could we kind of add together that with the ID cards, the student ID cards, having a code on the back, some kind of QR code where they could get Narcan if they needed it. How we keep talking about some kind of QR code, something on the back of the student ID cards, suicide hotlines, perhaps access to Narcan, on the back of the card too. I mean, if they're not going to put it in the high schools, I know across the country, in their health departments, they're teaching the kids how to use Narcan and giving it out. Can it be part of the health department?
Yeah. Go ahead. Sorry, Debbie.
No, I'm sorry. I'm thinking out loud, and you don't want me to do that because my head will go in a lot of different directions. I just think there's an opportunity to maybe combine a couple of things to make it stronger. And my thoughts aren't exactly focused 100% on how we could do it. I just know it's important.
Thank you for voicing that. I think we'll talk about new recommendations in just a moment. Senator Danyate, did you want to add to that at all? Okay. So one idea might be to think about if this recommendation could be to use settlement funds to cover the costs of naloxone for these types of events as part of a SURG recommendation. And that might help work around the cost barrier that was cited before. So it sounds like the committee thinks this is important so far, but isn't necessarily ready to proceed with a specific recommendation without some more research on this front.
Can I ask one more question?
Oh yeah. Mm-hmm.
Sorry. As far as the Good Samaritan law, I know we're going to have a meeting on it. Do we need to bring Attorney General Ford in on that meeting? Because we don't know the exact laws, right? I mean, I don't know how we can make a recommendation if we don't know if somebody's going to get arrested, if they have, what kind of possession they have on them and they call. I mean, it's that gray area.
So I'm hearing you say, Debbie, that maybe an SME from the AG's office or another type of group that could help us understand what the current law is, Emma, might be helpful for that particular recommendation.
Yes, thank you. Thank you.
Yeah, thank you. All right, if we could hop to the next slide. I know we're close on time here. And then other committee recommendations. So a potential recommendation on understanding sort of what the current scope is for students to access information about either through 988 or other types of systems for engagement if they need to reach out for assistance has been a recommendation that we've heard. Any other recommendations or a specific speaker who could talk more about a type of recommendation like a student ID card recommendation?
Debbie Nadler, for the record. Lisa Lee did this in Washoe. I always say that county wrong. Lisa Lee got this done. Perhaps maybe she could advise us
Great.
on the student ID card.
Yeah, we can reach out to Lisa, see who she might recommend, just to better understand the implementation statewide and what that looks like. And then other potential presentations that we've received at previous meetings were maybe one from the Boys and Girls Club. We had talked about bringing someone to talk about cannabis youth prevention efforts when we had talked about vaping before. And then, so is the committee comfortable proceeding with these presentations, or are there suggestions for any other presenters that you would like to see on these efforts?
Do we have time to submit some more after this meeting?
Yes, I think we're
Okay.
hoping to identify them soon so that we can
Okay.
plan out the next couple of months. So if committee members have one, I'd love to receive them, or Ms. Rodriguez could receive them in the next week. That would be helpful.
Okay. Okay.
That way we'll have time to reach out and schedule everyone.
Thank you.
All right, with this, I think we'll close agenda item number 6 and move on to agenda item number 7, which is a report out for the July 10th SURG meeting. I'm happy to present a brief summary of what was discussed during today's meeting, including our plan going forward to help refine any of the subcommittee areas as previously discussed, if the committee is okay with that movement.
Yes.
All right, thank you. And then, so we'll move on to agenda item number 8, which is our period of public comment. Again, she'll be limited to 3 minutes per person, and members of the public can comment on any matter that is not specifically included in the agenda at this time. So please, again, raise your hand or call in on the previous number provided. Ms. Rodriguez, do we have anyone for public comment?
Chair Johnson, I do not see anybody indicating they wish to provide public comment.
Right. With that, we can close the public comment period and move on to agenda item number 9, which is adjournment. Thank you very much to the attendees and committee members for joining today. I really appreciate your time and commitment to the search. And if you're interested in any additional updates, they're included in the slides here today. Thank you all so much.
Thank you, Jessica. Thank you all. Thank you, Emma.